Hi everyone, let's consider morphine. Now morphine is indicated in ACLS for acute coronary syndrome where nitrates were ineffective in relieving the pain. So you gave your patient a nitro, didn't work, still has chest pain. Tried another nitro, still didn't work. Morphine is now indicated. Now, what is morphine going to do to the patient? This is huge. When someone is having an acute coronary event, a heart attack, they are scared. They think they're going to die. And because of this, their body is releasing catecholamines, adrenaline, norepinephrine, and these substances are making the heart work. It's going to make it beat faster, harder, and it's using up more oxygen. No bueno. So we're going to give a narcotic, an opioid, morphine. And this morphine is going to relax the patient and inhibit the release of these catecholamines, thus throttling back on the heart, make the heart work less, preserving cardiac tissue. The other benefit to morphine is that it is a vasodilator, predominantly on the venous side, so it's going to reduce preload to the heart, reduce the amount of blood coming back to the heart, which can actually help improve coronary perfusion by taking some of that pressure off the inside chambers of the ventricles, allowing that blood to get through the tissue and get into the heart. Now, you do not want to administer morphine if your patient is hypotensive, obviously, so watch their pressure. You may have an instance where your patient may be a little volume depleted, they hadn't been feeling well, maybe their oral intake was low, and they were a little volume depleted. The body compensated by causing a little vasoconstriction, and that kept their pressure nice, above 100, everything's fine. You give a little morphine, you vasodilate them. In the presence of this volume depletion, their pressure can tank. When that happens, the treatment is fluids. You can administer 200 to 500 cc's of 0.9, get their pressure back up, but anytime you're administering fluids to a cardiac patient, you want to pay careful attention to their lung sounds. Listen to their lungs. You do not want your patient to develop pulmonary edema. No bueno. So careful listening to the lung sounds whenever you're administering fluids. Okay, so the dosing. How much morphine are we going to give them? In a STEMI, 1, 2, 4 milligrams. Repeat every 5 to 10 minutes. And what you're going to watch for is a change in their pain or a change in their pressure. That's what you're documenting. Every time you administer morphine, what was their pain on a 1 to 10 scale and what was their blood pressure? A few minutes later, reassess. Was the morphine beneficial? Did it help with the pain? Did it help with the pressure? Now, can you get too crazy? Can you just hook a brother up? You gave him too much Groovacaine and you dropped his pressure? Can you reverse it? Of course, you can give him a little Narcan. 0.4 milligrams if you have to reverse it. It's very rare. Of all the times I've given morphine in acute coronary syndrome, my patient never stopped breathing. But I wasn't giving him 10 milligrams at a shot. 2, 4, watch them carefully. I'm Mark, thanks for watching. See you in the next video.